Okay, so ladies and gentlemen, good evening. I'm very sorry for these technical issues we had, and the webinar is that late. But for those who have stayed and waited for their would you say now to change, but since I still see some party working group which is focused for the guidelines development for the internal internists and from the EFIM society. The head of this working group is Professor Kokorin from Moscow, from Russia. And the other speaker, the other professor is Professor Leon Marin from Sevilla, from Spain, who would present the method of these guidelines. My two colleagues from the board, Dr. Andrea from Romania. I hope we have already all speakers online, and I would like to give the stage to Professor Marin Leon. He will introduce the development and the methodology of the guidelines. I'm still not sure if we have these technical problems. Professor Marin Leon, do we have here? If not, we are very sorry. So if we can start with the lecture of Professor Kokorin.
Okay. Good evening, everyone. Sorry again. Yeah, Ignacio is connected now. Professor Ignacio Marin from Spain. Ignacio, can you hear us?
Okay, so we can see.
Can see you. We just started, so the floor is yours, Ignacio. You can upload your presentation and start your lecture.
Good evening. Good evening.
Good evening. Good evening.
Everybody. What a crazy situation.
Crazy word, crazy situation. What else to say?
Valentin, Happy New Year. We don't see since the last year. Okay, we are. Andrea, did you get the moderator? Okay.
Yes. So we can start now, and Zora just introduced the goals of this webinar, and so the stage is yours. So please, you can start with your presentation.
Sorry.
You can start. You can start.
We can start. Okay, thank you. Let me put the okay. I want to prepare this presentation within the. I want to put in the context of the quality of the evidence and the clinical and the improving of the quality and the clinical quality, because what guidelines try to be is just a tool to improve the quality. That is the context where we started with this. So I have no any kind of conflict of interest within this issue. I will briefly remark all these 6 points in the relation of the frame of the quality. The first thing, if do we know how to discern between good and bad evidence? We are very sure that we are very good clinicians, and we have all our practice are grounded on a very nice evidence and so on. But you can see that when we assess the quality of the evidence, like in this study that assessed the 1,600 Cochrane reviews since the.
Dr. Marin, I'm sorry to interrupt you, but we are not able to see the slides.
So you are not able
so
to see the slides.
If you can
Sorry,
share.
let me check. Let me.
if you can share. So
yes, let me. I don't know where to put. Where should I put this? I suppose. Let me check. Oh, to save pantalla. To put here. Save pantalla or something like save the screen.
no, we can see, but we see the camera, so we are not able to see your screen.
My
So we
screen.
cannot see. Yeah, we cannot see the slides.
Let me know where. I'm not very. It may be that video. So, let me check.
Share the screen.
At the
Yes,
bottom.
I put share the screen, but I don't know.
Yes, now
Okay.
it's uploading.
I'm not sure. What should I do? What crazy situation? Okay, let me check. How can I share? I don't know. I don't know. Representing over, but I don't know how to. I have opened my presentation before. I thought that I need to have opened the presentation before to connect, and it happened, but I don't know now why.
No, now we are seeing a sort of whiteboard.
Yes,
So,
yes, because I am exploring. Wow. No, exactly. There is more things. Compartir.
Maybe you will send your presentation to Andrea or Zora and they will upload it, or to myself.
yes, sure.
Ignacio.
We can do.
I don't know how to.
Can you send your presentation to one of us?
Ignacio,
and we will
if
share.
you are happy.
Yes, but Andrea, I think that you have my presentation.
Yeah, sure. So
Can
I
you
share
put
now.
in the screen?
Okay, now
Okay.
I share your presentation and you tell me when to change the slide.
Yeah.
Okay. But you have no, you have to disconnect your sharing, otherwise I cannot share.
You should stop your share.
Okay.
Ignacio.
I don't know now how I can I get out of this screen. I don't know exactly.
Yes.
Okay.
Okay.
Now
Okay, now.
I will share.
No. Okay. But okay.
So when you want to change the slide, you can just say next slide, and I will do.
Oh, next. Okay, thanks. Okay. So what he's saying is that just to put the production and elaboration of guidelines in the frame of the quality of the quality of the practice, the clinic of the improvement of clinical practice. So because at the end, a guidelines is a tool just to help the best practice to the clinician. So okay, next please. I have no conflict of interest, please. Next. Okay, this six point I will share with you briefly before going to the guidelines development. Next, the first one is that we think that we have a very good clinicians and we are very well grounded in the evidence and so on. but when you check the quality of the evidence, for instance, in this study that assessed 1,600 Cochrane reviews, they found that 9 in 10 of the healthcare interventions studied in this assessment are not supported by a high quality evidence. And the most important, that harms are underreported, were missed only in 37% of the studies. And so we move in a kind of uncertainty that really need us to prepare to how to handle this kind of uncertainty. Next, please. Why do you use low value tests and low value drugs? There is a lot of evidence about overuse and underuse, overuse of low tools, and overuse of and underuse of good tools and good drugs. So, and in part, it is why a lack of adaptation to the particular patient, and it is one of the best things of the EFIM guidelines program. This kind of uncertainty and so on, because to give us some sense of security, drive us to a therapeutic inertia. We do what we are doing and we think that it is okay, so that it is not a very useful way of improving our clinical practice. Next, please. Next slide. Go away. Next, please. There is a lot of evidence, for instance, in the bad use of antibiotics. In this article about antibiotic in their infection, we found that 48% of the patients were treated with antibiotic without confirmation of infections, and even in the patients treated properly, only 44% of the patients was treated with the dosing and the duration of the treatment correctly. So there is a lot of errors that are not supported by evidence that we need to improve. Go the next slide, please. This happens also for tests. There are a lot of overuse in tests. Next, please, which are related many of the time with overuse of resources and so on. In this article, you can see. I don't know if you can see it because I think it's very soft. It's very little the screen, but you can, that the 20% of the tests in regarding cardiac function tests, it was unnecessary. Unnecessary means that they don't produce any relevant benefit. So if you don't produce any benefit, you are only producing harm as disturbing the patient, increasing costs and resources, and so on. Next, please. It's happened to that, and it is an issue very important because many of the decisions are not adapted to the local circumstances and the target patient, and it is also other of the great advantage of the EFIM guideline program. For instance, in this article, next please, you can see that it is an article from the last number of JAMA in last December. When you use the cutoff for the day dimmer to decide that if the patients has low or high probability to develop VTI, you leave outside of the decision of the prevention of the group with low quality, very a lot of patients you don't identify. Please go the next. Go the next. You only identify previous one, please. You only identify with the physics cutoff of less than 500 d-dimer. You only identify in patients above 75 years old the 9% of the patients with low risk. And when you adjust and mobile the d-dimer cutoff to the age, you can identify 17 more people with this who can be classified at low probability that the results of BTA 3 months later, you see that are very sensitive and very so and very specific. So to adapting the cutoff, increasing in this case to the age, the cutoff of the limit, improve the specificity, maintaining sensitivity. And this kind of moving evidence produce, if we don't use it, produce as a bad sense of security that are not supported by evidence. Go next, please. And it happened also when you use overlabeling, when you put a tag of you have chronic kidney diseases. If you use the standard one, for people in 70 years old, 50% of the people should have more than 50% should be classified at grade 3, level 3 of chronic kidney diseases. But really, people 80 years old in the third grade, these people in the 3, 5, and 10 next years that they have, probably they will survive, they will not have any kind of sign of symptoms. So this kind of overlabeling can introduce you as to overuse of testing, overuse of treatment, of overuse of consult, and so on. Next, please. This kind of all these example just was only put to point that we need to be more critical. We need to be more skeptical. Don't be believers of the evidence. The evidence is something, it's a moving target that is moving because new evidence, and is moving because the presentation of our patients and even from our social or organizational situation. That is the situation. And that is what evidence-based medicine produce for us. We can improve the quality of our system based on available evidence that are available. Next, please. Go next, please. But what's quality? What matter to the clinician about quality? To resolve appropriately these 5 questions. If I do what I have to do, if I am doing it right, if the results are the best expected, and what tools do we need to improve? So that is if it is possible to manage and change to improve. Yes, it is possible, and we can use a lot of tools available. Next, please. And many of these tools are byproduct from the evidence-based medicine movement that yield to us is the establishing of standards, gold standards of what is inadequacy, what is overuse, and so on. Define the expected results with adjusting results, checking what are clinical relevant results instead of statistical significance, in checking the balance between harm and benefit of an intervention and so on. And part of the evidence-based medicine movement is just to develop evidence-based guidelines. Okay, next, please. And that is, we go just in the middle of my exposition. What is there is, if it is better to adapt very good produced guidelines and updated guidelines, or just to start producing new guidelines from the bottom. Next, please. We decided that if we go to the adaptation, we see that we can save resources because there are a lot of guidelines and good guidelines. So many times, if you produce new guidelines, you can produce more noise than evidences. You can get a better applicability and flexibility of the guidelines, because many times guidelines are very large. I mean, you started with diabetes, and they started with the children's, and then a lot of different situations, and just the patient, the target patients of our practice are just adult people. So you can give to mainly people in the type 2 diabetes and so on. So you can go straight to your target patient. So you can get more flexibility and more easy applicability for an adaptation and implantation of the guidelines recommendations. So next, please. That is why the EFIM approach to adaptation. That is, we decided to the approach of adaptation. Okay, next, please. We produced, elaborated first a methodological book, methodological guidance, which is published in 2020. Here are really the standard that we elaborated. Next, please. These standards are based on very validated and experienced tools. The first one is the adapter. It is a movement that some of us started inside the EGIN, the Guidelines International Network, some time ago, that has been updated also, and really we produced a toolkit, a nice toolkit for adaptation, a methodology for adaptation. If you adapt in the original produced guidelines, so you need to assess the quality of these guidelines. So we use for this a very well elaborated and validated tool, which is the agreed tool instrument, just to assess the quality of the guidelines that we get to be adapted. And we use the grade kind of a statement just to decide the quality and to qualify the quality of the evidence and to qualify the strength of the recommendation. With this, based on these three validated methods, and we elaborated the previous our methodology paper. Next, please. Our methodology paper just defined 3 phases with 17 steps. One phase is just the pre-preparation phase. It's just to choose the guideline topic. The topic will be diabetes, or will be BTA, or will be pulmonary embolism, or whatever. Secondly, just to establish a group, a working group, a team, just to select the external experts and so on. Okay, the second phase is just the elaboration steps itself. And the last one phase is just the dissemination and publication and dissemination and implantation of the recommendation. Next, step. Next slide, please. Okay, going just to the elaboration phase. The first one is just to build specific picos, to refine the picos. And we decided, go please to the next slide. We decided to define clinical very well, very specific clinical question, which with this method of the PICO, patient's intervention, control, and outcome, specifically defining it, and we use the people because we more or less change it to the patient intervention professional. The target of the guidelines are the internal medicine doctors, no all the doctors and so on. It's just produce guidelines for these people, for us, and also to take in account the healthcare context. So it is important because if you get, for instance, some guidelines elaborated in South Asia, maybe that now we're developing guidelines on sarcopenia, prevention of sarcopenia, but many of the studies are produced in Singapore, and the studies and where the toll and the weight of the people in Singapore may not be the same, and the diet and so on may not be the same as the current in Europe and so on. So to take into account the healthcare context in terms of population and also in terms of resources and so on is another important issue in order to adapt our recommendation, specify our PICO questions to facilitate local implementation. Next, please. Once that you have the very well defined and very specific 5, 8 picos only. Why only 6, 5 picos? Because many of when you are talking about diabetes, internal medicine doctors don't need that you explain exactly what is diabetes and so on. There are a lot of things that everybody knows, so you don't need to guide that. The people know it, so you must go to resolve some questions which are controversial, which are in doubt, which are not very well defined yet, and so on. So that is it's important just to go to this. You don't need a guideline, a guide or a map of your street. You know very well how is the street where you live. You know a map of a city that you don't know. If you go to visit Valentin to Moscow, okay, but you need but not in your city. So this is why we short the question that we wanted to resolve. Okay, once you have the PICO questions, you must get good guidelines where you could get good recommendation for you to adapt it. So we first try to find the guidelines to see that really these are well guidelines, good guidelines, updated guidelines, and so on, and then assess the quality of the guidelines. Put the next slide, please. And the selection for the guidelines, one that we share the documents that are not guidelines, okay, we assess the quality of the candidate guidelines by 4 independent and anonymous raters with this Agree2 tool. The Agree2 tool has 6 domains, but we use mainly 2. The domain 1, the scope and purpose, so just to see that the purpose of the original guidelines match with our topics, because if they are talking about I don't know prevention of diabetes, this is maybe not part of our PICO, just to check that the guidelines just are focusing our topics, and mainly the domain 3, the rigor of development. We want to be assured that the guidelines that the original guideline where we are talking recommendation to produce to adapt for our guidelines are well developed, evidence founded, evidence founded, and all obviously updated than for less than 5 years. 5 years. So next, please. Then we have the guideline. We have the question, the clinical question that we wanted to resolve. We have the guideline where we have a lot of recommendations. Then we need to select the recommendation from the primary guidelines. Many times, these good and well-developed guidelines, the recommendations don't agree, are some kind of disagreement in between. And so many times we need to review the evidence that are grounded, that support this kind of evidence of recommendation that don't agree in between the good and selected guidelines. We select the guidelines. If we select the recommendation for the guidelines, many times there are not one recommendation in one guidelines for one of our PICO, but there is only some recommendation in 2 or 3 or 4 selected guidelines and so on. And we assess the applicability of the recommendation to internal medicine practice. Just to say, if these guidelines are for patients who are in the ICU or are in a general ward, see these kind of things. If this thing is in the outdated, in the outpatient or in the ward, in the hospital, and see this to assess the applicability of the recommendation to our current practice. When we organize all the guidelines and we draft and clean and prune the differences of the guidelines, yes, we try to write the report, and we agree in the final publication, and we send it for publication to agents. I'll say that is so that way we elaborate. Please next a document available, tool, easy to use for our clinician. And you, young internist, how can participate? And how can you become a leader within the evidence movement? It is, you don't need to be a hero or invent new tools or so. You should use the closest to your environment. There are a lot of tools that can help us to practice best supported by evidence. I put here some examples. Choosing wisely. This is promoted by the British Medical Journal, in which is and Kokorin collaboration. Just to they compare different interventions, and they say, please, wisely, the wise and the better solution is just to choose this selection instead of this other, and they give you some report. Less is more is also some kind of articles promoted by JAMA, which is more focused on testing and so on, but I'm very interesting too. The more, which is promoted by McMaster University in Canada, which they review a lot of original articles, clinically relevant. So they don't say great article that has not a close relation with the clinical practice. So, and then some expert select and this article, they send it to 3 different experts to decide that if what did they think about the quality of the evidence, and how important is the result of this article to improve the quality. and then they produce a list of articles with good. McMaster is open for people who wanted to collaborate. Really, I closed recently my collaboration with them because I'm retiring for a lot of places. But really, if some of you wanted to be part of the MOOC, I can put in contact with them. The Cochrane, of course. There is another way, more easy and more for you to participate. That is, be part of the EFIM Guideline Working Group. Every year we produce two new guidelines. So it's a good idea if the young internists incorporate to the EFIM Guideline Working Group, because it has a lot of advantage for you. One of them is you make very good networking with people. Secondly, you have a deep insight in a topics, which is very useful and increase your knowledge. Thirdly, you use a new methodology and which is good for you too. And finally, you get at the end of the year a good paper. So you are author. You could be author of an article that should be published in Edging. So I think that is a lot of advantage, and you have a lot of possibility to be included within the evidence movement and to integrate in this very collaborative kind of production of improvement of quality. Okay, thank you very much.
Thank you very much, Professor. I would maybe postpone the discussion for the end of the webinar, and then we can continue with the lecture of Professor Kokorin. And if you have any questions from the audience, please use the Q&A session after the end of the webinar. And the speakers would be happy to answer all your questions. So the stage is yours, Professor.
Good evening, everyone. Can you hear me and see my slides? Is it working? I hope at least so. Okay, so first of all, I would like to thank Zora, Andrea, and Catalin for the idea and organization of this meeting, because I really suppose this is very important issue for promotion and dissemination of our working group activities. Let me introduce myself a few words. I'm a person who is just a moment, who is working with the methodology which was proposed by Ignacio, and we have to follow it. And my presentation will be much more practical than the Ignacio one, and I will give you an example of such a critical adaptation process we used in our working group for acute heart failure. And I'm a professor and the head of Department of Hospital Therapy of the People's Friendship University of Russia in Moscow. And I also chair of the EFIM Critical Appraisal of Guidelines in Internal Medicine Working Group, and scientific secretary of the Russian Society of Internal Medicine. So indeed, acute heart failure was not the first our activity and not first our appraisal. We started 7 years ago with the pulmonary embolism and community-acquired pneumonia task force, which were substituted later with acute heart failure and hyperglycemia task forces. And now we are working on 2 more projects on sarcopenia and venous thromboembolism prophylaxis, which I suppose will be presented during the European Congress of Internal Medicine in Vienna in March. And I invite you to this session, which will take place on Thursday, if I'm not wrong, with the presentation of our Friday, definitely, with our adaptation. So why we choose acute heart failure as the topic for our appraisal? Because it's still a really major healthcare problem, especially in the elderly patients. And despite of our achievements, the patient with acute heart failure has very poor prognosis. It still represents a challenge for clinicians, especially in old and multimorbidity patients. So we established a task force which was composed of 11 members from 11 from 7 countries from Europe, and we directly followed the process, the methodology which was described by Ignacio a few moments ago. So we defined the list of 7 PICOs, 7 key questions, and tried to find the answer, the replies to these questions. And this PICOs was related to diagnosis, risk stratification, therapy, and transition of care of patients with acute heart failure. So at the beginning, to cover with these speakers, we performed the midline searching and identified more than 250, 273 papers and guidelines related to the topics of our appraisals. But after screening and assessing of eligibility, only 8 clinical practitioner guidelines were included in our process of adaptation. So let's look how it looks like. And the PICO number 1 was what investigations do we need to differentiate acute heart failure from the other conditions with similar presentation. And we should say that differential diagnosis of acute heart failure with the conditions with similar clinical manifestations is rather complex. Unfortunately, there is no single test that can help us and clinicians to discriminate patients with acute dyspnea, congestion, and hypoxemia, which are the most often presentation of acute heart failure. There is a general consensus in the clinical practitioner guidelines to recommend the use of natriuretic peptides assay as the first line test to rule out acute heart failure. Don't forget that we have to use higher cutoff values for elderly patients, for patients with atrial fibrillations or kidney failure. So to confirm the diagnosis of acute heart failure, we suggest also ACG and echocardiography. And there is a general agreement across guidelines that imaging tests like chest X-ray and lung ultrasound, point of care, are suggested to exclude respiratory diseases. Additional tests such as routine blast tests, procalcitonin, D-dimer, COVID-19 testing should be performed in case of special clinical suspicions. So we proposed in our document the 3-line algorithm of the differential diagnosis workup in patients with clinically suspected acute heart failure. That includes measurement of natriuretic peptides as a first line, general testing with the ACG, echo, chest X-ray, lung ultrasound, and routine biochemistry as a second line, and specific testing as a searching for the specific reason of acute heart failure for the third line. PICO number 2 was what are the best prognostic tools for patients with acute heart failure to stratify prognosis and refer to the intensive care unit. And there is general consensus in practical guidelines that natriuretic peptides and cardiac troponins should be assessed at hospital admission for stratifying of the prognosis, because they are the strong independent predictors of poor outcomes in patient-related heart failure. Biomarkers of myocardial injury or fibrosis, such as soluble isoform of tumorigenicity to suppress that protein or receptor or galectin-3, are emerging as possible additional tests in such clinical scenarios. Today, there is no single validated risk stratification score for predicting prognosis for fast referral patients with acute heart failure to intensive care unit. But ABCDE stages are based on clinical and hemodynamical criteria, which was originally proposed for shock patients, but should be also considered in the other acute heart failure patients for certification in order to prompt referral to intensive care unit. This criteria also lack validation in specific patients groups, so we should be careful with this usage in acute heart failure. Picker number 3 was about the strategies to quantify and manage conditions that determine better outcomes in patients admitted with acute heart failure. And our task force decided to divide this picker into 3 sub-questions: strategies to quantify congestion, actions to promote fast recovery, and actions to reduce the risk of hospitalization or mortality. So the practical guidelines review identified 8 recommendations: 1 for quantification of congestion, 4 for fast recovery, and 3 for reducing hospitalization and mortality. So to quantify the degree of congestion in patients with acute heart failure, it is recommended to use echocardiography and natriuretic peptide tests. Chest X-ray and lung ultrasound may also be considered useful for this purpose. For fast recovery, we should use non-invasive positive pressure ventilation in patients with high respiratory rate and desaturation, intravenous loop diuretics in case of fluid overload, and second diuretic acting at different sites if the diuretic response on loop diuretics is unsatisfactory, and intravenous vasodilatators in patients with preserved blood pressure. The most important measures to reduce readmissions and mortality are diuretics, administration, titration, and optimization of the guideline-directed medications, and a diuretic adjustment plan before discharge of patients. So picker number 4 was what are the strategies in patients with acute heart failure to manage arterial hypotension, low cardiac output, and lead to more effective symptoms resolution and mortality reduction. And we can conclude to short-term continuous intravenous inotropic support may be reasonable to maintain systemic perfusion and preserve organ performance in hospitalized patients with documented severe systolic dysfunction, arterial hypertension, and low cardiac index. But also vasopressors, renal replacement therapy, and temporary mechanical circulatory support may be considered in patients with cardiogenic shock. Picker number 5 was the most complex and the biggest picker in our appraisal because it was related to the specific treatment of patients with acute heart failure and different comorbidities. And usually the patients hospitalized with acute heart failure has many comorbidities. Among the most common are diabetes, chronic obstructive pulmonary disease, iron deficiency, kidney dysfunction, and atrial fibrillation. We selected the best recommendation for these pathologies in our patient with acute heart failure, and also added ventricular arrhythmias to our appraisal and to this topic, not because of their frequency, but mostly because of the importance and impact of major events. So in patients with acute heart failure and diabetes mellitus, CGLT2 inhibitors are recommended and we should avoid administration of dipeptidyl peptidase 4 inhibitors and also thiazolidine diones to the patients with heart failure, either acute or chronic. Patients with acute heart failure and COPD or asthma could be treated with cardioselective beta blockers. In case of combination of acute heart failure and iron deficiency, intravenous administration of iron supplementation is recommended in symptomatic patients with heart failure with reduced ejection fraction or moderately reduced ejection fraction. And iron deficiency. While oral administration of oral supplementation and systematic use of erythropoietin-stimulating agents to treat iron deficiency or anemia are not recommended in patients with heart failure. One of the clinical practitioner guideline review the expected impact of kidney function after starting renin-angiotensin system inhibitors, ARNI, CGLT2 inhibitors, or mineral receptor antagonists in patients with heart failure, as well as the features of heart failure treatment in patients with low estimated glomerular filtration rate or severe chronic kidney disease. And we selected 6 recommendations on this issue. Let me just very briefly show you this recommendation to save the time. 2 practitioner guidelines focused on the management of arrhythmias in patients with acute heart failure, and their recommendations concentrated on the clinical management of acute heart failure and ventricular arrhythmias, as they are the most common arrhythmias in patients with acute heart failure. So we identified 7 recommendations for management of acute heart failure, of atrial fibrillation in acute heart failure, and you can see that they are mostly similar to the one without heart failure. And in case of ventricular arrhythmias, invasive coronary angiography in patients with angina and implantation of cardioverter defibrillator, both for primary in case of reduced ejection fraction, and for secondary prevention for all patients who have recovered from ventricular arrhythmias are recommended. Picker number 6 was when we should discharge the patient with acute heart failure from internal medicine department. And the short answer is when the signs and symptoms of congestion are resolved, clinical condition is stabilized, and the management plan is also optimized. And the last picker, finally, picker number 7, was related to what are the most effective strategies for reducing readmission and mortality after discharge of patients with acute heart failure. And important that the strategies should be started even before initial hospital discharge. So we can recommend quality improvement programs, pre-discharge natriuretic peptide assay, and switch from ACE inhibitors to ARNI if the heart failure happens during the intake of ACE inhibitors, but only after stabilization of the condition. Very important is the early post-discharge phase, the nearest 1-2 weeks after discharge, when we should assess signs of congestion, medication tolerance, and initiate or uptitrate of evidence-based therapy. It is recommended frequent and thorough follow-up visits during the first 6 weeks after hospital discharge for acute heart failure, and also correct adherence and to an evidence-based medication regimen, including CGLT2 inhibitors, regardless of ejection fraction, is associated with improved patient outcomes. And also a new option is usage of very SIGWAT, and it can be considered in patients with reduced ejection fraction to decrease the risk of readmission. So our appraisal process was published in the European Journal of Internal Medicine early in 2024, and it is open access document. You can find easily either on the EFIM website or EGIM website. But afterward, we also prepared the webinar with this appraisal process, which is available on the EFIM Academy website. And also we try to disseminate our document, and we prepared several publications with translation of the appraisal document to Russian language, at least in Russia. And we also made several discussions both in the journal and in web community. And we had an example of Spain on the Cardioteca website and forum. They discussed, the members of our working group discussed our appraisal document. So to conclude, our task force prepared the guideline critical appraisal and adaptation for internist document on active heart failure. And we suppose that this document offers a quite simple and updated guide for clinicians dealing with complex patients with active heart failure. And I would like to thank you for your attention and give you the best regards from cold winter snow Moscow, and invite all of you, our young colleagues, to join our working group, our task force. We will have a working group meeting in Vienna during the EFIM Congress, and probably you can also visit members of our working group in the EFIM Young Internist Corner during the Congress. So thanks for your attention. And probably it's time now for discussion.
Yeah, thank you very much, Professor, for an amazing and really practical lecture. I would like to kindly ask the audience for any questions to discussion for Professor Marin or for Professor Kokorin. If you have any questions, please use the Q&A section. Meanwhile, if maybe the audience would be encouraged, I would maybe ask Professor Kokorin. You mentioned also the use of ultrasound and point-of-care ultrasound in the use of the primary physical examination, because now it's increasing in the clinical practice. So when do you...
Sorry, very strong echo effect. I completely can't understand what I'm talking. Probably the others who are not now participating in the discussion should mute their microphones, and then the sound will be better. Catalin.
It is better now. Can you hear me? Yes. Yeah, thank you. So I wanted to ask you, meanwhile, the audience will maybe be encouraged to have any questions. I would like to ask you for the use of the point-of-care ultrasound in patients with a suspicion of the heart failure. Do you use it in every patient, or maybe in which situations do you use the ultrasound of the lungs?
The lung ultrasound?
Yes.
What do you mean I use? Myself? Or in my hospital, in this country, in Europe, where, on which level? In my practice,
your center, your practical, your practice.
My center, we usually try to use it. It depends on the availability of the doctor who is managing and who can perform it. Unfortunately, not everyone till today is able to perform it, but we are trying to study, to teach our postgraduate students and the young doctors to the point of care ultrasound. And of course, the future is that the doctor will use it to every patient immediately after admission. Unfortunately, it's not always still today possible in every case, but during the daytime, it's almost to everyone.
Okay, thank you very much. Okay, any other questions from audience or Andrea, please?
And I just comment because I definitely agree with Professor Kokorin. I mean that I try to use my clinical practice and also to teach to my young fellow to use the use of the ultrasound scan for the lungs and also for the extravasal congestion. But the problem is that is not so spread the teaching of this. So perhaps as it's important that also we as a scientific community and scientific society we need to improve the teaching of this method. So I definitely agree. I don't know if in Spain, Ignacio, Marin, do you use in your clinical practice?
Yes, at least in my hospitals, we have a large experience using the guidelines. So we all our quality assessment you has the standards. We select some standards defined by the guidelines that we decided, and and really it is happen. It is used to be very frequently used because more many times we have in our tab or in our telephone or whatever or in papers or and we use it very frequently. And it is, you remark, Andrea, one thing that which is very important, and I think it's a challenge that we have as a group. That the one thing in the diffusion, we have an agreement with the aging that the national journals can give a copy in their national languages of the guidelines published in the agent. So without all the methodology and all the introduction and so on, just only the list of recommendations and a brief discussion. And so it is a pity because I think that we can have a large diffusion and a more possibility to improve the use of these guidelines. Another thing is that we are since the first guidelines that we produced to the new ones, we are elaborating this with a lot of algorithms just to facilitate the clinical decision process. So not only words, but also algorithms just you can use your pocket. You can check what is the next step and so on. This kind of things. And another thing is that one thing that we have been doing in another here in a movement for guideline development in Spain is that you always has to elaborate also a guidelines for patients. When you make a guidelines for diabetes or whatever, you must do a paper, a briefing of the guidelines for patients. It is very interesting because it is an effort to maintain a dialogue so that when you are in the nurses and so on are trying to teach the patients and so on in their own diseases, they give us 1, 2, 3 pages, which some drawing and so on, and pictures, just to, and it is very important because if the patient asks to the doctor, please, your guidelines say that I must do whatever. So you should know your guidelines and you must respond in that way. And you introduce this kind of people which are questioning the doctor. So I need to fit. And I think that we have this other challenge, this other challenge, the one of the dissemination in the national languages, the production in some patient part of the guideline. And there is another challenge that we have with this, that is that we need to update, Valentin. We need to update the guidelines. You see, for instance, I remember now exactly in one of these PICO, some of the guidelines of the original guideline that you are getting the recommendation and for 2017. So and now we are in 2026. So really, maybe that these recommendations are not updated also. So that we need. So that is why we need a lot of people just involved in the group, because we need not only produce new guidelines in topics that we think that we need, but also to update the just published guidelines every year, not at least two. So I think it is very important the way we have. I can announce you that today we have elaborated the third draft of the paper of the sarcopenia guidelines. So I think that before the Congress, probably we will have our paper sent to be published. So because there are no many discussion in between after the second draft. It's a good news.
This is a very good question. I see Professor Kokorin hands up. So
yes, a lot of thoughts after Ignacio's speech, and I have to remark several points. First of all, the most difficult part of our process is not to create the guidelines and not to make an appraisal process, not to form the working group or write a paper. The most difficult part is the dissemination and implementation of the guidelines. And unfortunately, I will say that we have a huge reserve to improve it now, because very few people in Europe even knows that EFIM produce a kind of critical appraisal of guidelines products. Even the working group works for 6 years, and we promote it every year on the European Congress of Internal Medicine and the journal, on the other conferences. Still today, a very small proportion of the doctors, of the internists, knows about this kind of activity. So, of course, we are very interested in your active participation in this process. And as we all belongs to EFIM, we should do a lot to improve this issue. Concerning the ultrasound, there is a ultrasound working group in the structure of the EFIM, and they usually have a how to say courses during the European Congress of Internal Medicine, and as I remember, it's also on the program of this year Congress in Vienna, so we can invite our colleagues to join this course as well. About the guidelines to patients, I will say that due to the Russian experience, in every national guidelines, we have a section with the information for patients about this pathology. And finally, about the idea of updating of appraisals. You know, this is a problem of each guideline and each paper, each scientific publication. When you publish it in the journal, it became dead. You cannot change nothing. So if you'd like to do something more, probably the best option is the online version, which can be transformed, uploaded, changed according to the most recent publications and so on. And we have such experience. I can tell you about the how to say the Polish McMaster course of internal medicine, and they produce also a kind of textbook or the web version, which is alive, which is updating day by day with the new interviews, with the new information. So this is a very important and very interesting process, but for this case, we need more sources, we need more people, because indeed our working group is quite small. We have about 20-25 person, doctors, specialists, which are moving from one working group to another one. And this is really a problem. We need a new blood and new members and your activity as well. So sorry for a long.
So we can say that this is a call for action, in particular, perhaps for young internists, that we can join you. So how is the process in which we can ask for be part of this working group, if you want to say it for our younger audience?
Sure. We will have a working group meeting in Vienna, also on Friday, on the 27th of February, and everyone can join us and become a part of our working group. Okay, any more questions from the audience?
I have a question for Dr. Ignacio Marin.
Not only young internists.
Sorry. Please, Zora. Okay. I have a question for Dr. Ignacio Marin. You presented us 17 steps in the adaptation process. In which step are the most disagreements between the medical experts?
Sorry, I don't understand the question. In which steps?
In which you presented us 17 steps in the creation process. In which step tend to arise the most disagreements between doctors, between medical experts?
The discussion of the PICOs is very hard. It's very hard because it's not easy to build very well specific PICO questions, because it's not easy just to decide which outcomes are better and so on, but also because of the interest of some of the participants. No, many one are more interested in some things, and others are more interested in older people or whatever. So, and in the second scenario is just when there are disagreement between the recommendation of the guidelines and a new article that just was appeared the month before the discussion. So they say, okay, these 4 guidelines say to do that. But there is now a new article that decided that there is something, a very important effect or whatever. So, but this is an evidence that has not been assessed and has not been put in context with the other, like in a meta-analysis or whatever. To convince to the proposal of this new evidence used to be that to refuse this new proposed evidence is very hard many times, because we decided that if the American Diabetes Association say in December that you must do that and that, and is discussed, and there is a lot of reason, they give a lot of reason on why they got this recommendation. We think that if the new evidence or the new article don't move the decision of the recommendation, we decided that not affect this, and unless all the group decided that it's okay. Many times when there are not very good evidences many times the recommendation from the original guidelines are a consensus decision, because there are no evidence. And then in the meantime appears a new evidence. So we decided many times to get it. So it is to manage this kind of discussion. And the other and the last moment of the discussion, of great discussion, is obviously in the order of the authors, which is a very a strong fact, and also in the writing the report, because many times the editor always say, please short, and many people wanted to give a lot of information, but the information of the guidelines should be the recommendation, not very large introduction or very large discussion, but the recommendation. So these are the three scenarios with the most difficult. One is personal, another is methodological, if you accept or not, and the other one is procedural. So what is the procedure to decide the PICOs? But to build very well developed PICO used to bring at least 2 or 3 months. Many times we have made a survey to the internists, to the society, of what do you think are the most important problems that you have to manage sarcopenia patient, or the food or the diet in sarcopenia people. This, and then just the people say, no, the problem is to decide the calories, or decide how to prepare the food, or this kind of things. And then we can select, the expert panel can select facilitate the selection of the PICO, but really to be the PICO get a lot of time.
Thank you for your answer.
Yeah. Okay.
Professor, I see no questions from the audience, so I think anyway we are pretty late, and thank you very much to all participants who stayed with us even despite such a long delay. We are again very sorry for the technical issues we had, but hopefully it will never happen again. Thank professors that you attended this webinar even despite this time delay, for great lectures, and hopefully this cooperations between the young internists and the critical appraisal of guidelines internal medicine working group would has just started and would continue, because the young internists are often those who mostly need the guidelines because they need some support in the clinical decision. So thank you very much, and I would also like to invite anybody from the audience who will be in Vienna in the EFIM conference. We'll have the Young Internist Corner again with the cooperation, and we will host speakers from the critical appraisal of guidelines, the working group, and we'll discuss the hyperglycemia guidelines. So for those who will be in Vienna, we are looking forward to meet you personally there. So thank you very much again, and have a nice evening and good night.
Okay. See you in Vienna.
Thank you very much.
Bye-bye.
See you in Vienna.
Thank you.
See you in Vienna. Goodbye.
Goodbye.